clearly, if you have one myocardial infarction, it is more likely that you will have further myocardial infarctions or other cardiovascular events, which is why it's important to keep your LDL low. Now let's look at some of the trials which were done long back. This is 2001, the role of statins in ACS, Miracle trial, 3,000 patients. And the conclusion of this trial, the statin therapy after an ACS is associated with significant reduction of mortality and morbidity. That's very clearly important. And there's no association with baseline LDL. So even if your LDL at baseline is not very high, you will still benefit from lowering it further. Then you have the A to Z trial, again in ACS patients, again an old trial in patients with ACS, early intensive statin therapy has a favorable trend towards reducing cardiovascular events. We should also look at the inflammatory pathways because, as we all know, atherogenesis or atherosclerosis is partly an inflammatory disorder, and therefore you must look at the inflammatory biomarkers as well. And one of the commonest things that we know of is CRP, and we know that if you have low CRP and low LDL, your risk is less, and if you have high CRP and high LDL, then your risk is maximum. So those with the high inflammatory quotient and high LDL will have the greatest risk and the greatest benefit. And that was, of course, seen for the very big Jupiter trial, which is a primary trial, primary endpoint trial looking at MI, stroke, and revascularization and cardiovascular death, and patients with the high CRP and high lipids, and you can see this very significant benefit of 44% with the use of rosuvastatin. So clearly we know that these drugs work very well. We also know that recurrent events are less likely to originate from a new atherosclerosis, are as likely to originate from new atherosclerosis as they are from the culprit. So you put a stent, you have a culprit lesion, yes, the culprit lesion can produce problems, but it's the non-culprit lesions which equally produce problems, and this is where we need to stabilize those plaques in the non-culprit vessels. Now we know that statins promote plaque stability with reduction of LDL cholesterol. So it's very important to remember that it's not just reducing the LDL, but you're also reducing the plaque burden in the coronary arteries. A superior LDL reduction along with plaque regression can produce a significant reduction in the MACE. And that's why if you look at the ESC guidelines, early initiation and continuation of statins is recommended for patients to achieve goals. So clearly,
please share the PPT.
And this. Can you see it?
Yeah, doctor, you can start.
Okay.
I'm Dr. Jamshed Dalal from Kokilaben Hospital in Mumbai. Today I'm going to talk about the need for aggressive dyslipidemia management and the role of lipid control in coronary artery disease. Now we all know that lipids are one of the most critical modifiable risk factors for acute myocardial infarction. If you can see the risk out here, you can see lipids are number one, smoking, psychological causes, that is anxiety and stress, and hypertension, diabetes. So in fact, lipids play an extremely important role in development of myocardial infarction. A raised LDL cholesterol was observed in up to 70% of CAD patients, and only 1/3 of these patients actually achieved an LDL target cholesterol as per guidelines. So clearly the fact is that the large number of patients have high LDL, but very few of these patients are treated in spite of all the clear guidelines. Now, all of you have seen this graph many times before. Secondary prevention or primary prevention, the lower the level of LDL, the significant benefit in terms of reduction of events. So if you reduce your LDL from 100 to 60, you can see the dramatic reduction in your cardiovascular events. Also, we now use the term low lipid years. That means the longer you keep your lipids low, the greater the benefit it will be. And this is particularly important for familial hypercholesterolemia, where the earlier you start, the less likely that the patient will have problems and will live longer. So clearly, whether it's hypercholesterolemia, which is familial or otherwise, The sooner you start and the longer the duration of low lipid years, the better for the patient. We also know that 1 in 5 patients after a myocardial infarction will have another myocardial infarction, stroke, or a cardiovascular related death. And repeat happens up to subsequent 3 years. So clearly, if you have one myocardial infarction, it is more likely that you will have further myocardial infarctions or other cardiovascular events, which is why it's important to keep your LDL low. Now let's look at some of the trials which were done long back. This is 2001. The role of statins in ACS, Miracle trial, 3,000 patients. And the conclusion of this trial, the statin therapy after an ACS is associated with significant reduction of mortality and morbidity. That's very clearly important. And there's no association with baseline LDL. So even if your LDL at baseline is not very high, you will still benefit from lowering it further. Then you have the A to Z trial, again in ACS patients, again an old trial in patients with ACS. Early intensive statin therapy has a favorable trend towards reducing cardiovascular events. We should also look at the inflammatory pathways because, as we all know, atherogenesis or atherosclerosis is partly an inflammatory disorder, and therefore you must look at the inflammatory biomarkers as well. And one of the commonest things that we know of is CRP, and we know that if you have low CRP and low LDL, your risk is less, and if you have high CRP and high LDL, then your risk is maximum. So those with a high inflammatory quotient and high LDL will have the greatest risk and the greatest benefit. And that was, of course, seen for the very big Jupiter trial, which is a primary trial, primary endpoint trial looking at MI stroke and low LDL, your risk is less. And if you have high CRP and high CRP and high lipids, it's very significant. So those with a high inflammatory quotient with the use of and high LDL, so clearly we know that these drugs work very well and the greatest benefit. We also know that recurrent events very big Jupiter are less likely to originate primary trial atherosclerosis, primary and as likely to get MI and low LDL, your risk is less. They are from the and if you have high CRP and high CRP and high lipids, yes, the culprit very significant. So those with the high inflammatory non-culprit with the use of and high LDL, so clearly we know that these drugs will risk and lastly non-culprit. We also know that recurrent events very big Jupiter are less likely to originate primary trial atherosclerosis, primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, yes, the culprit very significant. So those with the high inflammatory non-culprit LDL and high LDL, along with clearly we know that these drugs will significant and lastly non-culprit. We also know that recurrent events very big Jupiter are less likely to this why we put on the atherosclerosis, primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, yes, the culprit very significant. So those with the high inflammatory non-culprit LDL and high LDL, along with clearly we know that these drugs will start in early after we also know that recurrent events very big Jupiter are less likely to this why we put on the atherosclerosis, let's go to primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, this is very significant. Those with the high inflammatory non-culprit LDL and high LDL, along with clearly we know that these drugs will start in early after we also know that recurrent events very big Jupiter are less likely to this why we put on the atherosclerosis, let's go to primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, this is very significant. Those with the high inflammatory non-culprit LDL and along with clearly we know that these drugs will start in early after we also know that recurrent events very big Jupiter are less likely to this why we put on the atherosclerosis, let's go to primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, this is very significant. Those with the high inflammatory non-culprit LDL and along with clearly we know that these drugs will start in early after we also know that recurrent events very big Jupiter are less likely to this why we put on the atherosclerosis, let's go to primary and as likely to get MI and low LDL, your risk is as they are from the LDL, high CRP and high CRP and high lipids, this is very significant. Those with the high inflammatory non-culprit LDL and
with just rupees 500, we decided to see how much to get extra space and here's how it works. Top it
and therefore become more less lipid rich
Then
and
you can with just a P500, we decided to see how much food on the
As you can see, new OBS shortcut
and
just
therefore you can see
appeared
from these
on
trials,
the
you must
desktop.
start
But now
early
in
to
case
get
we
the
would like
initial
to run
benefit,
this
and then
OBS,
continue for long periods of time to get further benefit. So clearly statin
the latest
therapy is a
version of the
continued
OBS
therapy
Studio. For this, simply
starting
go
from
towards this
almost the
website,
first
link
day
will
of
be in the
ACS
description,
and continuing
and then
for
we will
virtually the
go
lifetime
towards the
of the
download
patient.
and
And
click
we all know
on
the statins are
download
most
via
important in
zip.
prevention
In case, of course,
cardiology from
we
the
are
cardiovascular
using
point of
Windows.
view. But
So
we
in
know
case we are using
that in
Windows,
spite of
download
using
zip.
statins, even
And
high
as you can
doses,
see now, we will
there
choose
still
where
is a
we want to
residual
save
risk.
it.
And how do
And
we
as soon
treat
as
this
it's
residual
downloaded,
risk?
we can simply open this
One, of
zip
course, is to
file,
improve compliance.
and
As you
then
can see,
we
half
want
the
to
Asian
create a new
patients on
folder for
lipid-lowering
this
therapy do
OBS
not
because
achieve
as we
LDL
can see,
goals.
at the
So one
moment we got
important way
already
of
multiple
achieving LDL
OBS
goals
installed.
is not
We
just to
got two
increase
on
the
our
dose of new
desktop
multiple
and
drugs,
one
but
which
to
I
make sure
have
that the
simply
patient
pinned on my
complies
bar,
with the drug. So
which I'm
compliance is a
using
very
at the
important
moment to
aspect.
record this video. So
we know that
we got
there are a lot
already
of
two
worries
OBS.
about
We are
statin
going to
therapy and
create
all
the
these issues have
third
been
one.
raised.
So
But
for this,
clearly
as I
none
said
of these
already,
issues are of
we
any
are
significant
going to
importance
extract
in
this
terms of
downloaded
worsening
bin
the patient's
data
condition.
to new OBS Studio
Now, this
folder. So
graph
first we
nicely
are going to
explains
choose where we want
if
to
you have a
have our
patient
OBS to be
who's on
installed.
low
In my
adherence,
case, it's going to be in this
low
PC and
intensity,
in the D.
and as low
And then I'm
adherence
going
both,
to create
then his
new
risk is
folder.
going to be
So
virtually
folder
very bad.
OBS.
If on the other hand
let's
you have a
say
patient who goes
webcam.
all the way to high adherence,
Now I can
with
simply
a
open
good
this folder
intensity
and drag
and a
and
good
drop
adherence,
there all
and of course the
of
maximum
those
benefit will
folders
be seen,
from
and
the
in
down.
between. So the aim should be to use maximum intensity. The advantage is even if the patient is not so adherent, a greater intensity, even with less adherence, will have beneficial effect. So maximize your dose and try and improve the adherence. Now, as I mentioned, statins alone may not do the job, and we have a very nice drug called ezetimibe. And this was clearly shown in the Improve It trial. Again, patients about less than 10 days post ACS, they did not have very high LDL values, and they were given simvastatin versus a combination of ezetimibe and simvastatin. Ezetimibe is a very simple drug, one dose, 10 milligrams once a day, no titration, fairly cheap, doesn't get absorbed, acts in the gut only, preventing cholesterol absorption, very minimal side effects, if any. And this study clearly showed the reduction of LDL is not very dramatic, about 10 to 15 milligrams, which is good.
Because we would like to run this OBS.
And the ezetimibe is a very
It will say
simple drug.
OBS
One
is
dose,
already
10
running
milligrams,
because it
reduction,
actually
no
is
titration,
on one
fairly
OBS
cheap,
we are
doesn't get
recording this
absorbed,
video.
acts in
So
the
we
gut
don't
only,
want to launch
preventing
it
cholesterol.
anyway.
Clearly a
I will
non-LDL
cancel.
drug
I
has
will
shown to be
right click
better.
on this new created
So
shortcut.
Improve It showed multiple things. One, that even non-statin lowering of
Going to be in
LDL will
this
reduce
PC and in the
cardiovascular
D.
events.
And then I'm
Suggesting
going
it's
to
just not
create
something
new
magical in
folder.
statin,
So folder
but it's more the LDL reduction
OBS,
which benefits.
let's say
And we know that
webcam.
now also from PCSK9 inhibitor
Now I
trials,
can simply
that it
open
is
this
the
folder
LDL reduction
and
which is
drag
the
and drop
most
there
important.
all of those
And we
folders
also know
from the
that lowering
downloaded
LDL
zip
from
file.
70 to 53
Okay, so now we got
with
basically
ezetimibe
downloaded
produced
and
the
installed
benefit. So lower
completely
is
new
better.
OBS.
And again,
But in case we
ezetimibe
would
was proved
actually
to be
want to
safe.
create a
So
new
it
shortcut
clearly
on our
reaffirms
desktop
the
and to
LDL
also make
hypothesis
sure that we
that
can
that's what
run
prevents
multiple OBS at the
cardiovascular
same
disease.
time, we need to go to
The
our
other
bin,
issue that we see with
64 bit,
statins is that
and
when you
then
give
I will
statins,
create
it
the shortcut
upregulates
on
the
the desktop. So I will right click on
When
this
you
OBS
upregulate
for
the
application,
PCSK9,
and then I will go to
you get
center
more
and
LDL
desktop. Create
receptors.
shortcut.
If you
Just
block the
like this. As you can
PCSK9,
see,
you get
new
increased LDL
OBS
receptors
shortcut
and
just
reduction of
appeared
LDL
on
cholesterol.
the desktop.
So
But
when
now
you
in
give
case we would
statins
like
and you
to
have a
run
rise
this
of
OBS,
PCSK9, there's an
it will say
important
OBS
reason
is
to
already
use
running because
PCSK9
it actually
inhibitors
is
so
on
that
one
the
OBS
LDL
we are
receptors will
recording this
increase
video.
and
So
LDL
we don't
cholesterol
want to
will come
launch
down.
it anyway. I will cancel.
So here
I
you have
will
your
right click
LDL.
on this new
It's
created
caught by
shortcut.
the
I
LDL
will go to
receptors,
properties,
taken
and then I
into
will
the
add here one simple
hepatocyte,
command
and then
in the
destroyed,
target line
and then
to actually make sure that I can run multiple
LDL
OBS at the
receptor
same
again
time.
goes up
So
to catch
behind
more
this
LDL
target,
particles.
what is basically the
But the
location
body
of
also
where
has a
our new OBS
counterbalancing,
is
which is a
installed, I will
PCSK9
click one space
enzyme.
and dash dash
Now, when you
or
have the
minus minus,
LDL
and
receptor
then I
and the
will
LDL
simply
and the
write
PCSK9
portable.
molecule attaches to that,
Just
it
like
doesn't allow
this.
the break. It
Apply.
allows it breaks
Okay,
down in
now we
such a
can
way
also, of course,
that even the
rename this
receptor is
for the
destroyed.
OBS
So therefore, there's a loss of
webcam,
receptors,
for example.
and therefore LDL will rise again. That is why we use PCSK9 inhibitors to stop this PCSK9 so that the LDL can attach to the receptor, LDL is destroyed, and the receptor can go back to the surface to catch more LDL. And this is how PCSK9 inhibitors became popular. As you can see, placebo versus ezetimibe, yes, about 15% reduction. And you see with evolocumab, which is a PCSK9 inhibitor, almost a 55 to 60% reduction. So major reduction compared to ezetimibe. The first PCSK9 trial was called the Fourier trial, very large trial, 27,000 patients.
Just like that.
Stable patients with
now when
established
I will run
cardiovascular
it,
disease. And
as
then
you could see,
comparing
new
evolocumab
auto
with
configuration
standard of care.
wizard
This is
just
not
appeared,
placebo in the
and
sense of
it
true
did not
placebo.
ask
This
anymore
is statins
whether
plus
we
whatever
want to
standard of
launch
care
the
that is
another
usually
OBS
used.
as one OBS is
And
running.
you can see that there's
So
a significant
thanks this,
benefit,
just like that,
10%
you can set up
reduction
and run
in the
multiple
patients
there
with an
all
NNT
of
number
those
to treat would
folders
be of
from
35. And the more recent
through
MI that
OBS,
you
we
have,
are going
the
to
greater
create
the
the
benefit.
third
But this,
one.
the future,
So for this, as I said already,
past
we
distant
are
MI,
going
the
to
benefit is
extract
less, but
this
still there,
downloaded bin
but the
data
benefit is
to
very
new OBS
significant
Studio folder.
in
So
patients
firstly, we
with
are going to
recent
choose where we want to have
And then you have
our
a second
OBS
trial called the
installed. In
Odyssey
my
trial,
case, it's going
which
to be
again
in
used
this
a
PC
different
and in the
PCSK9,
D. And then
alirocumab.
I'm going to
Again, these were
create
ACS
new
patients,
folders.
very large
Folder
number studies,
OBS,
again with the
let's
standard
say
of care.
webcam.
You can see that in that group
Now
also
I can
the
simply
LDL
open this
reduction in
folder
that study is
and
about
drag and drop there
55%.
all
So whichever
of those
PCSK9 you
folders
use
from
is
the
about
downloaded
55
file.
to 60% reduction.
Okay,
of
so now we got
LDL.
basically downloaded and
And again, if you
installed
look at the
completely
major
new
endpoint,
OBS.
death,
But in case we would
ischemic
actually
stroke,
want to create a
hospitalization
new
for angina,
shortcut on our
again, you see
desktop
a
and
very
to also
significant
make sure that
benefit in terms of the use of evolocumab or alirocumab in this particular stage. And also very interesting, we also found that there was a reduction of all-cause death. So it's not easy to find all-cause death with treatment, but you can see after 1 year, the all-cause death separates out and becomes significant. So not only cardiovascular events, but cardiovascular death and all-cause death is improved. Another interesting thing which was seen from PCSK9 studies is that the lower you brought your LDL, so as the LDL went lower and lower, and let's look at this chart. LDL more than 100 brought down slowly to less than 20, and you can see the relative risk reduction. The relative risk reduction was 3%, 6%, 15%, and increases to as much as 24%. So very low LDL levels will produce almost 1/4 reduction in your cardiovascular endpoint. So there's a tremendous incremental benefit for every lipid LDL reduction. Not only is it the coronary arteries, we always talk of coronaries, but if you look at the major adverse limb events, and many of these patients have polyvascular problems, stroke, peripheral vascular disease, and you can see a very significant 40% reduction in peripheral limb. So if a patient has a vascular problem in the leg, he's likely to get into gangrene. A simple management with PCSK9 can reduce his chance of limb ischemia and the need for amputation. That's a thing we often don't remember. I think it's a very, very important thing. The other important effects of evolocumab, it reduces LPA by about 25%. Now, there's no drug statin